time to hear from Dr. Ajoy Dutta. He will be talking on cardiac MRI clinical implication.
Good afternoon, Honorable Chairperson, respected teachers and colleagues. Welcome you all in Viability session. I'm going to present Viability. Actually, I can do without MRI. This is my statement. My objectives of this presentation is what is viability, why it is important, how to assess it in CMR, and why I choose CMR. We know the definition of myocardial viability from previous speaker, but in a nutshell, it is the improvement of contractility after revascularization, improvement of contractile function after low-dose dobutamine, and reduced reperfusion and wall thickness. So goals of viability assessment are the identification of patients that would benefit from revascularization, prediction of recovery of regional and global LV function after revascularization, and in advanced heart failure, it helps to take decision-making whether patient should undergo revascularization or LVAD or transplantation. So why viability is important? The Allman data showed in a meta-analysis in patients with viable myocardium, I mean hibernating myocardium, which is interchangeably used in American literature, showed that revascularization was associated with 80% mortality reduction annually compared with medical treatment. Rather, in patients without viability, mortality was not improved by revascularization. Rather, it may produce some periprocedural complication in complex PCI or CABG. So, in viability, there are so many tests. We have already heard about echo, next nuclear study, and MRI. I choose MRI because it has high spatial and temporal resolution, excellent signal-to-noise ratio, free choice of imaging plane, no need for geometric assumption, radiation-free, interobserver variability is very low, technique is very simple, and beyond viability, MRI can also detect other co-founders like aneurysm, ischemic MR, thrombus, clot, microvascular occlusion. So let's see the resolution. Even 1 gram of infarct tissue can be detected by MRI because it has extreme resolution. And the upper panel showing the PET imaging, the resolution, and lower panel showing the MRI where there is closely figured out the LED territory infarct with thrombus. This is 20 years back. It's a dog model, animal model showing after ligate coronary artery, this is the infarct tissue, which matched with MRI very closely. So technique is very simple. Insert peripheral IV, place a patient in scanner, at least 1.5 Tesla, take cine images in short axis stack, 2-chamber, 4-chamber, and inject gadolinium contrast. And this is the extracellular contrast accumulates in the dead tissue or scarred tissue. After 5 to 10 minutes, healthy myocardium washouts, and then takes delayed images in short axis stack, 2-chamber, and 3-chamber. So methodology, actually we look for 4 things. Number 1, end-diastolic wall thickness, wall motion abnormality, whether it is normal or hypokinetic, and assess absence or presence of infarction, and low-dose dobutamine in certain patients. So in viability imaging, in a patient who has had an infarct, if the wall motion is normal, the myocardium is viable. Let us see the normal wall motion in MRI and abnormal wall motion in MRI. Here the basal and mid, inferior and infralateral walls are hypokinetic. So the principles of imaging in MRI, all infarcts enhance, and white is dead. After MI, from the beginning, it enhances and it remains forever. And all non-enhancing myocardium are potentially viable. Let's see a patient, a 60 years old man who had history of anterior MI, admitted in hospital, and undergo CAG, showed occluded LAD. And first of all, we see the wall motion in the MRI. It's showing the basal, anterior and anteroseptal wall, mid, anterior, anteroseptal, infraseptal, and apical. All the segments are severely hypokinetic. And inferior infralateral walls are normal motion. And in the LG pattern, the same area shows the more than 50% infarction as evidenced in the bullseye chart, anterior wall, anteroseptal, and basal, mid, anterior, anterolateral, anteroseptal, and apical, all the segments. So if you combine both wall motion abnormality in LGE, we can report in a bullseye chart. So in this patient of 70 segment, 10 segments are non-viable. And this report is presented here. The green color is the viable myocardium, and non-viable myocardium is shaded in pink color, and yellow are viable and hibernating. So in a flow chart, we look for, first of all, systolic function. If it is normal, then normal. If it is abnormal, then look for delayed enhancement. If there is no enhancement, it is viable hibernating myocardium. If the enhancement is less than 25%, it is viable. And if it is more than 50%, it is non-viable. And in between 20 to 50%, there is 50% chance of recovery. In that case, we can take help, really help from the dobutamine stress echo, which patients would undergo for revascularization surgery, or revascularization or surgery. So I do not go for the low dose dobutamine, same principle as dobutamine stress echo. In real life practice, actually we look for global function, wall motion, wall thickness, and LG pattern. Mainly wall motion and LG are the key parameters for the viability assessment. So strength of cardiac MRI is for the dead tissue imaging. It has excellent sensitivity and negative predictive value. For the living tissue, on the principle of contractile reserved dobutamine testing, it has specificity 91% and positive predictive value 93%. So if you combine both parameters, its position, it is better than even PAT. So if you combine end-diastole wall thickness, contractile reserve, and scar tissue imaging, it is better than others. What else do we see beyond viability? We surgeons and physicians are not happy with only see the viability. You can assess the ischemic MR, what is the mitral ring, and how can you plan the surgery. You can assess the plan for revascular surgery, what is the extent of scarring, and what is the viable myocardium, and planning of the reconstructive surgery for the large aneurysm. We can assess also the microvascular occlusion in an infarct-related artery of RCA. And these are the poor prognostic factor for the revascularization. And also we can show the LV akinesia with thrombus. So take-home message, viability is important. CMR is a comprehensive one-stop test. And wall motion LG are the key parameters. There is no comparison with SPEC because MRI is far, far better than SPEC. So LV volume, ejection fraction, MVO, thrombus and aneurysm are important prognostic factor for the decision making. Thank you all.